to do some fundamentals, some fluid and electrolytes, the way they can ask you. I'm going to simplify it. You don't need like a bunch of videos on fluid electrolyte. So this is the first question. I'll show you how they can take fluid electrolyte and turn it into a big question for you. Okay. So, and let's provide care for a client with the following findings. This is what you find. Okay, this is what they've given you. You have to read it carefully, try to analyze it, then you answer the question, right? A urine output of in 24 hours was 80 ml. Serum osmolarity is decreased. Urine specific gravity is elevated. Serum sodium is 130. Which intervention the nurse should anticipate in the plan of care is a select and apply. You don't have to pick everything, right? You don't have to pick everything. You pick answers that you're confident on. Serum osmolarity, right? Osmolarity is what? Oh, I can put it in. This is decrease. Over 24 hours is too low. Serum osmolarity is also decreased, right? Then you have specific gravity. Urine specific gravity is elevated. Serum osmolarity, sodium is also decreased. This is endocrine case. This is the way they can connect endocrine with fluid and electrolyte. Can you figure out what this patient have? If you can't, then you'll be guessing. But you have to figure out what this patient have. Put your words together. I've shown you the pathways, right? Urine output is low. What condition will cause urine output to be low? Serum osmolarity is also decreased. What condition will do both at the same time? What condition will make your urine specific gravity to be elevated? And what condition will make your serum sodium to go down? It goes down because serum osmolarity is down, so it's consistent. So which condition can give you this information for SIDH? This patient has SIDH, classic SIDH, right? So if you know it's SIDH, what do you want to do with in terms of management? In content, SIDH, it means their sodium is too low. We want to bring the sodium up. The sodium, that means its percentage is less than 1%. Therefore, you should not give them anything that is less than 1%. Don't give them any fluid that is less than 1%. That's all. And that's your answer. After that, then you look at it. Which of those is consistent with the management of SIDH? This is fluid and electrolyte, how you can apply it, right? The patient is already fluid overloaded. We're going to fluid to restrict the patient. Patient fluid overloaded, well, we get rid of some fluid. Patient fluid overloaded, but his sodium is low, we give them 3%. The sodium is less than osmolarity and a sodium concentration, you should not give them any fluid less than 1%, right? 5% dextrose in water is going to make the sodium go low. 10% dextrose is all going to dilute the sodium. So that's why these three is not part of it. Number 2, a nurse is caring for a client diagnosed with hypertonic dehydration. Which finding the nurse should expect? Select or apply. No answer the question. Go for the buzzword. Read it from the back. I know select or apply. I'm going to get a bunch of answers. I don't have to pick everything. Which finding the nurse should expect? Which one is consistent with the disease? A nurse is caring for a client diagnosed with what? Hypertonic dehydration. This is the content. Hypertonic dehydration. There's 3 types of dehydration. There's isotonic dehydration, there's hypotonic dehydration, and there's hypertonic dehydration. Sometimes the NCLEX will do that. They're trying to confuse you and put these words there. You have to know the definition between the 3 of them. So Who know what is hypertonic dehydration is? Hypertonic. Hypertonic dehydration. I'll give you the content. When we say hypertonic dehydration, that means it's based on the fluid lost. So you're going to lose water or you're going to lose salt. What will make your blood hypertonic? Which one do you have to lose more to make your blood hypertonic? You have to lose more. So hypertonic, that means you're losing more of water. So I'm losing water greater than salt. If I lose too much water, what will be left will be salt. And therefore, my blood will have hypertonicity. It's thicker. That's all. After that, look at the answer and see which conditions is doing that. Is somebody having diarrhea, vomiting, consistent with hypertonic fluid? Think about what they're losing. If you're vomiting, you're losing what? Think about it. It's an isotonic. If you have diarrhea, you're having isotonic fluid. If you are vomiting, isotonic fluid. So this is not consistent with hypertonic dehydration because the fluid you're losing is isotonic. You're losing the same amount of salt and water. Cystic fibrosis, what is their major problem? Salt, right? They have salt issue, right? They're losing more salt than water. Addison disease, they're losing most of their salt. Therefore, this is wrong. The next one, client lost more water than salt. Yes, right? He's losing more water than salt. Therefore, that is consistent. When you lose more water than salt, you become hypernatremic. Fever is one of the signs of hypernatremia. Think about diabetes insipidus. What are they losing? Mostly water. They're just losing water, not salt, right? And patient in DK ketoacidosis, mostly water and glucose. No salt is lost. And if you lose all your water, your serum sodium is going to go up. This is a hard one, but this is just using the content. This is why you don't have to memorize. I explained to you what is hypertonic dehydration. I'm losing mostly water and my blood will become hypertonic. Hypotonic dehydration, I'm losing more salt and my blood become liquid, water. Isotonic, I lose salt and water, but you have to know which condition causes that. Diarrhea and vomiting is an isotonic fluid that you're losing. Therefore, those are your answers. And this is evaluating a client who has hyponatremia, right? Which of the following etiology the nurse should consider in the evaluation? Don't worry about it. Just break down the question. Just break it down. Which of the following I should consider? What is the patient problem? Hyponatremia. And you know your normal sodium is 135 to 145, right? Therefore, if it's hyponatremia, it's less than 135. Which of these conditions will make my sodium low? That's all. Let's take one of them. SIDH. What is the complication of SIDH? What happens? Is your sodium high or low? Hyponatremia. Adrenal insufficiency. What is the problem? Do they have a lot of salt, sodium, or their sodium is low? What do you guys think? Adrenal insufficiency. Is your sodium low, normal, or high? Is your sodium low, normal, or high? They don't have aldosterone. Therefore, their sodium cannot be that high. It's going to be low. If you drink a lot of water, this is one of the things people with the mental health, they can get water intoxication. They become hyponatremic and they seize, they have seizures, especially schizophrenia patient. They can drink a lot of water psychosis, and then they will have hyponatremia and they get into trouble. If you gain a lot of weight, you're going to retain water. You become hyponatremia. If you're not taking a lot of salt, become hyponatremia. If you have a lot of diarrhea, you're going to lose all your salt, right? If you're not eating nothing by mouth, MPO, no salt. How about lithium? Lithium is a content, right? Think about it. Lithium. What do you know about lithium? And is it lithium causes hyponatremia or hypernatremia? This is one of the teaching they teach you in mental health about patient on lithium. What do you tell them to do? What do you tell them? Those in taking lithium, what do you tell them? One of the teaching that you teach them is based on this content. It's based on that. You tell them to do certain things. You tell them, don't increase your sodium too much. Don't decrease your sodium. If somebody tell you that you should, if you're taking lithium, you should increase your sodium, it's the wrong answer. Don't decrease it. Don't increase it. Take the same amount of sodium. Maintain normal sodium because potassium, sodium, and lithium exchange each other. And so lithium does not like sodium. So when you take lithium, it's going to make you hyponatremia. And therefore, you should take adequate amount, not too much, but adequate amount. So lithium is a common cause of hyponatremia. How about cirrhosis? It does not affect your sodium. Cirrhosis is a form of fluid overloaded. So they have too much fluid, and therefore that causes hyponatremia. How about hyperaldosteronism? Look at it. If it sounds a really big word, don't worry about it. Hyper, a lot of it. Aldosterone, too much aldosterone. If you have too much aldosterone, is your sodium low or high? It's content mastering, right? Is your sodium low or high when you have too much aldosterone? Remember, aldosterone is affecting the way you improve your blood pressure is by doing what? Holding on to sodium. Therefore, this is not going to cause hyponatremia. Heat stroke is the same thing. It's going to hold on to your sodium because you've lost too much water. And steroids, cushion, hold on to water. And sodium follow. So this is our sodium follow. You hold on to sodium and water follow. So these three causes hypernatremia, and the rest, these are your causes of hyponatremia. If you don't know them, this is but you don't have to memorize. There's nothing memorization about fluid electrolytes. Otherwise, it will become really hard. Understand the content, look at the answer choice, and answer it. So from A to I is the right answer. Okay. An S scale for a client with severe traumatic brain injury with ICP of 20. Which fluid the nurse should anticipate in the plan of care? Once again, the best way to answer question from the back, select or apply. Which fluid I should anticipate? Okay, I should anticipate. The nurse care for a client with TBI with ICP of 10. Then you underline your buzzword, TBI, ICP of 10. So I have somebody with TBI, it's ICP of 20, sorry. So you have ICP. Therefore, what are you going to do? You want to lower the ICP. How do you lower ICP? Pull fluid from the brain. Which fluid will pull fluid from the brain? You got to have what? Think about it. So which of those you will give to a patient with the ICP of 20? This is the application that you see in the test, and then you can figure out what they're trying to do. They're taking a bunch of concept. You know, I have ICP. My ICP is high. In order to do well, you got to pull fluid. How do you pull fluid? You got to use specific fluid. What kind of fluid you use is the answer. Think about it. Which fluid pull fluid from one place to another? That is the key. So which one are you going to use? But at the same time, you have to think about the pathophysiology. think about the underlying problem. You can't choose any of them without thinking about what does the patient have. So which fluid is acceptable in a patient with the ICP of 20? It has to be hypertonic solution, something greater than 29%. Lactate ringer is an isotonic fluid. 29% is an isotonic fluid. You cannot use it. 5% dextrose, it depends on where it's located. 5% dextrose is D5W. It's in the bottle sitting on the nursing station, that is what? An isotonic fluid. But when you infuse it, it becomes hypotonic. Still, you cannot use it. So the right answer is 3%. Only one answer. But I intentionally said it. It's just for content. And then has attended staff education program on types of fluid. So do you know your fluid? Do you know which one they are? What do you need to use? The next will complete the sentence below to indicate correct understanding of the teaching. So this is just to show you all the fluid you need to know and what it means. 0.9% normal saline and lactate ringer. What kind of fluid are they? Are they isotonic? Are they hypotonic? Or are they hypertonic? The hypertonic means they're greater than 1%. Isotonic is the same as plasma. Hypotonic is less than plasma, so it's less than 0.9%. So isotonic has the same thing as 0.9%, hyper greater than 0.9, and hypo less than. So 0.9% normal saline and lactate ringer, isotonic fluid. 5% dextrose in water in the 1 liter bottle. Pay attention. 1%, 5% dextrose in water in a liter bottle. So it's in the bottle sitting in the nursing station. What is it? 5% dextrose. That means sugar water. Is it isotonic or hypotonic or hypertonic? You see, so that's the thing. 5% dextrose in water. What kind of fluid is it? I just explained it to you. It's an isotonic fluid. But when you infuse it, it becomes hypotonic. How about D5W? It's not 5%, but it's 50% dextrose in water. What is it? Is it hypotonic, isotonic, or hypertonic? Think about it. If 5% is isotonic, now you have 50 times of that. You don't have to memorize and multiply it times 5. 50 times, or no, 10 times of that. So that has to be hypertonic, right? Now, 3% normal saline, 5% normal saline, 10% are all what? 10% normal saline. I forget the normal saline, but what are they? They are all hypertonic fluid. So be really, really high concentration. This is the caveat. The last one, don't fall for it. It's a trap, right? D5W, if you had LR to it, or if you had normal saline to it, or if you had 0.5% or 4.5% to it, what kind of fluid is that? So when you take D5W, think about it. You take 5% dextrose in water, and if you pour it in lactate ringer, which is an isotonic fluid, there is no way the concentration will go down. The same thing, if you pour dextrose in water to normal saline, there's no way it's going to be hypotonic or at the same time isotonic. You've added too much fluid to it. Same thing, if you take D5W and you add it to even half normal saline, 0.45%, it cannot be isotonic, it cannot be hypotonic, it has to be higher. This is your lecture on fluid and electrolyte in the simplest form to understand all of them. So this is an hypertonic fluid. You see them ask all these questions all the time, especially if you're in a nursing school. This is the summary of all the fluid, what it means, and then how you can recognize them. Which of the following clinical finding is associated with hypernatremia? Some of these signs and symptoms you have to know. But there's one key. Hypernatremia is mostly, it has some neurological side effects, but mostly external, right? You can see that signs of dehydration and then everything is so dry. That's why your sodium is so high. But you may have some neurological complaint, right? You may have neurological complaint associated with that. This is the only, these are the, and this one, the phosphorus, that's the only one that is hard to determine signs and symptoms. So for that one, you have to know a little bit. When the sodium is high, things get sticky. Once again, when the sodium is high, things start to get sticky a little bit. So if you see an answer choice that look like stickiness, at the same time, they can have neurological problem, right? So those two things is the way to remember signs and symptoms of hypernatremia, right? They can have neurological problem, right? Hyponatremia, you will see signs of ICP, brain edema. So like number one is signs of ICP. This is the hyponatremia signs. This is also hyponatremia because when your sodium is low, your brain get edema and you show signs of hyponatremia, ICP. So this is like hyponatremia. You can get this in hyponatremia. You can get this in hypo, but at the same time, you can get them in hypernatremia. So this is one of the answers and confusion, right? So those are one of the answers that you can see in this condition. Okay, and then one of them is seizures. These are the three things that cross over from hyponatremia and hypernatremia. The rest is all stickiness. I don't know how to explain it. Everything that gets sticky. Let me see if I can show you. You see sticky mucous memory, that's classic related to hypernatremia. It's very sticky. Your tongue also gets sticky, dry. These are the way to remember some of the key aspects of hypernatremia. Your tongue will be swollen, right? And you're going to have fever and a muscle cramp, right? Muscle cramp, it's seizures, confusion, and lethargy. Those are the key aspects of it. Mostly sticky signs and symptoms. Lethargy, confusion, and seizure is consistent with the hypo and hyper. But these are the key aspects of hypernatremia. They are stickiness, muscle cramp, weakness, headache, and nausea consistent with hyponatremia. This one is a little bit difficult because it's hard to teach, but you have to understand, like when your sodium is high, things, stickiness, and the rest you can just eliminate it. So I can't explain it the best I can. This is the only way I can explain it to you. But this is the one that is easy. You should not memorize any electrolyte signs and symptoms except sodium and a little bit of phosphorus. But they're going to most likely give you potassium, calcium, and magnesium. If they give you sodium, that's the one you memorize. Like I try to give you the stickiness of it. But the rest, these ones, you don't have to memorize. And I will give you the key as easy as possible. Potassium, magnesium, and calcium. How do you remember signs and symptoms? Go by the system. Take the major system in your body: cardiac, brain, muscle, GI, kidney, and lung. These are the 6 major symptoms and system you should know. If your potassium is low, okay, potassium is going to follow the direction of the system. The system is going to go the direction of the electrolyte, except what? your heart, which is cardiac, and your kidney. That's all. I've given you the answer. If your potassium is low, every system they give you, look at the direction that the science is going. It should follow that direction of the electrolyte. The only person, two things that go in the different direction is your heart and your kidney. When it comes to magnesium, it's different. Magnesium and calcium are the same. If the levels are high, symptoms should go opposite direction except your kidney, which go in the different direction. That means if your magnesium is low, every organ in your body will have signs and symptoms that look like it's going up. Your muscles will start to twitch, right? But your kidney output, urine output will go down because you have hypocalcemia. You don't want to get rid of your calcium. This is the way I learned electrolyte. Most of the four organs in your body will follow direction. If your potassium is low, your GI tract slow down. You get constipation. But guess what? Your kidney goes up. Why? You want to get rid of and try to ensure that it exchange it with the sodium. That's why the output goes up. So those are the way you can remember these kind of signs and symptoms, right? So I've talked about it enough. Therefore, in this table, you just have to fill it. Hypokalemia, what direction your heart will go? I told you if your potassium is low, well, everything follow the same direction except your heart and your kidney. So this one go up. Your brain symptoms is going to go down, right? Your muscle is going to follow the same direction. Your GI tract will go down because you have hypokalemia. Your kidney is going to go up and your lung go down. What does that mean? Your lung go down? Your respiratory rate goes down, right? But when you have hypokalemia, your heart rate goes up. So if they give you answers, that is the way you can figure out those information. And when it comes to hypokalemia, hypocalcemia, right? If your calcium is low, your heart rate will go up. Same thing, when your magnesium is low, your heart rate goes up. Your brain will also follow the same direction. So is your magnesium. Your muscle will start to twitch because you have hypocalcemia. The same thing, your magnesium, muscle is going to twitch. Your GI tract will speed up, right? Because your symptoms is opposite. Same thing, magnesium will speed up. But when it comes to your kidney, it's opposite. Kidney will go down, right? And then magnesium will go down. Your lung is going to go up and your magnesium will go up. This is the way you can remember signs and symptoms related to systems and the individual electrolyte. Sodium does not follow this pattern. Phosphorus does not follow this pattern. This is the way you can remember how they will go. They will give you something. Look at the symptoms. If you say tachypneic or bradycardia, tachycardia, muscle cramp, constipation, diarrhea, low urine output, and deep tender reflex is going down. Look at it. When I give you your potassium, your magnesium is low, your reflexes will do what? Will go up. This is where you have muscle going up, right? When your magnesium is high, your reflexes go down. That's why it's the opposite way. So this is the way you should remember electrolyte in the direction it goes, okay? And this I already talked about it. Match the following dehydration with appropriate description. So what is isotonic dehydration? What is hypertonic tonic dehydration and what is hypotonic dehydration? Well, loss of salt more than loss of water more than loss of salt, loss of water is equal to salt are the same. So which one is which? Which one is isotonic? Which one is hypotonic? Which one is hypertonic? Isotonic is easy, right? You lose the same amount of water and salt. Hypotonic, that means what is left? You got to lose a lot of salt so that your blood will have what? More water. So whatever is left is hypotonic. You have to lose salt more than water. And hypertonic, I have to lose too much salt rather than that of water. And that's what it's going to be. Which of the following the nurse should anticipate in the plan of care? Once again, application. Sodium of 155 is what? Hypernatremia. What are you going to do? Think about it. Your sodium is high. What would I do? What is your management? Do you give them more sodium or you give them less sodium? If you give them less sodium, what is your strategy to lower the sodium? Think when you see the question like that, you got to think what you can do. I have too much sodium, it's abnormal. I have to do something to get rid of it. And then you look at the answers, ask yourself, do you give them more sodium or do you don't give them more sodium? Do you give them more fluid? So which of those is your management of somebody with a sodium of 155? Sodium is too high. That means it's greater than 1%. You should not give them anything higher than 1%. So it should be lower, right? So that the best fluid you can give them is to dilute it. Dilute the sodium. And what is the best diluter, fluid you can use to dilute things? The best fluid to dilute is water, D5W. It's just sugar water. So that is going to dilute it. So this is the easy way to dilute the fluid. Which ones do you dilute? Right? 0.45%. Easy to dilute. Why do you want to restrict them? You want them to drink. If you're giving them free water, then let them drink free water. Don't over-select. Think about the answer choice before. If I give you the dextrose 5% to dilute your water, I can let you drink the same thing. So you should not restrict their fluid. Fluid restriction means they should not drink. So we should let them drink. So we should let them drink. You should not give them 0.9%. And then furosemide is going to worsen their fluid. If you give them furosemide, right, they're going to lose more water. The sodium is going to go up. Even though they will lose a little of sodium, but they will lose more water than sodium. And therefore, A and B are the right answer. This is the management of hypernatremia. This is a video. You can watch it in adapting class, but this is content mastering in fluid in electrolyte. So A and B are the right answer. But this is, you got to break it down into easy way as much as possible. And you can see explanation. Sodium is hypernatremia state and indicate fluid loss. Client does not need any more sodium. Objective is to bring sodium down. Give fluid with concentration less than 0.9%. So that's how you can do it. A nurse is caring for a client who has been vomiting for the last 4 days. Which fluid the nurse should anticipate? I told you, right? When you vomit, what is happening? What kind of dehydration is that? See how I'm going to answer this question. If I vomit, what kind of dehydration is happening? If I'm having diarrhea, what kind of dehydration is happening? Think about it. Sometimes they will trick you, but sometimes this question is straightforward. Don't overguess. You know the patient is being vomiting for 4 days. He's going to be having isotonic dehydration. Which fluid is isotonic dehydration? Which fluid is an isotonic? Pick an isotonic fluid. That's all. Otherwise, you overpick and you get it wrong. It's a selected apply. You pick, you know the answer, but then you lose point. This is no isotonic fluid. Okay, when you infuse it, it becomes hypotonic. So it's not isotonic now. Lactate ringer is isotonic. 29% is isotonic. 3% normal saline is not isotonic. 5% normal saline is non-isotonic. 5% albumin is a colloid. Therefore, you only have two answers, right? So don't overselect, break down the question, and you can see that you can answer it easily, right? It's isotonic dehydration. Therefore, you need isotonic fluid. So answer the question like that. When they give you a question, make it easy to be managed. Same thing. Selected apply. Okay, there's a bunch of them. I'm going to pick it. Which of the following clinical data the nurse should expect? I should expect one of them, right? And nurse provide care for a client with projectile vomit for 4 days and decrease oral intake. Same idea, right? What is the buzzword here? What are the buzzwords in the question? What are the buzzwords in this question? What do you think? What are the buzzwords in this question? Projectile vomit, right? He's been vomiting for 4 days and he's not taking anything. What kind of problem is he going to have? Isotonic dehydration. So we know this patient is dehydrated. It's isotonic dehydration. It doesn't matter what they're asking you. The answer is you don't have to worry. It's no fluid that you got to think about it. Patient is dehydrated. Now, all I'm looking for is this. I'm not looking at anything. If I'm taking this test, I write dehydration and say, if I'm dehydrated, what should I expect? Is my BUN going to go up? Is my hematocrit going to go up? Is my creatinine going to decrease? Is my glomerular filtration rate and be elevated? Is my what? Serum osmolarity goes up? Is my urine specific gravity decrease? That's all. Look at it and say which one is consistent with that. So which one do you expect? If you lose water, what are you going to expect in this situation? Right? Your BUN is going to dry up and the value is going to go up. Your blood will become concentrated, right? Your hematocrit goes up. What about your creatinine? Does your creatinine decrease? Does your creatinine decrease? Does your creatinine decrease when you become dehydrated? Your creatinine is supposed to go up. So it does not decrease. Does your GFR increase? Does your GFR increase? That is your glomerular filtration rate. Does it increase when you get dehydrated? The content is here. Your creatinine and your GFR is opposite. If your creatinine goes up, your GFR goes down. A higher GFR means things are good. So when you dehydrated, things are bad. So your GFR is supposed to go down and your creatinine goes up. So dehydration, I'll put dehydration will cause your creatinine to go up and will cause your GFR to go down. That is the content. So dehydration causes creatinine to go up and GFR to go down. So D is wrong. your serum osmolarity is going to go up. Your urine specific gravity is going to go up because there's no, you absorbing all the fluid that you want. And so this is what it's going to look like. This is classic board question. They can give you pyloric stenosis. They can give you this. And they will put you this there, pyloric stenosis, and you got to figure out. They give you a patient who's been vomiting. You got to figure out. You got to think about each of them. You can't memorize this. So those are the right answers. And this is assessing a client with small bowel obstruction receiving NG tube decompression for 4 days. Which electrolyte abnormality the nurse should expect? This one, everybody is supposed to know. If you don't know, it's okay. When I put the NG tube in, okay, there's certain things that happen. Sodium, potassium, and your bicarbonate. Anybody vomiting will have specific electrolyte problem. So if you have NG tube sucking everything out, your sodium go down, potassium go down, your bicarbonate go up, and you develop what? Hyponatremic, hypokalemic, metabolic alkalosis. So we have metabolic alkalosis. What do you think this patient will show? What kind of signs and symptoms they will show? This is, I'm giving you acid-base status right there. This is how you can connect them. How do you correct metabolic alkalosis? How do you correct it? What do you think the patient will do to correct metabolic alkalosis? I say flip it. Flip it. You take the metabolic and you make it what? Respiratory. You take the alkalosis and make it acidosis. This is how you do compensation. I have a video on ABG, easy way to do compensation. So your metabolic alkalosis will become respiratory acidosis. Look at the answers and see. Sodium supposed to go down, is up here. Potassium is supposed to go down, is up here. Chloride is supposed to go down, is up here. Bicarbonate is greater than 24, is consistent with what? Metabolic alkalosis. So the right answer is C. So that's why this one is C. This is what you're going to see, metabolic alkalosis. Now your compensation will be respiratory acidosis. And then provide care for a client who developed grand mal seizure, right? Seizure, right? During morning assessment. The nurse received the following laboratory value. Which electrolyte should the nurse suspect? So this is what you have. Which of these conditions causes seizures? You have sodium 130, potassium 4.2, BUN of 18, creatinine 1.1, calcium 7.2, magnesium 2. And this is what I was teaching you on the table, right? When you develop seizure, this is the way you can break down this question. It means your symptoms is going up, right? The symptoms is going up. And we talk about few electrolytes. We never talk about sodium. We talk, so you know this BUN is not going to do that. This is not going to do that. And I told you potassium follow same direction, right? So which one you want to think about? If potassium follow the same direction, potassium is normal. There's no way you're going to get seizure from that, right? Sodium hyponatremia, you know, this is very low. So that's the problem. Calcium symptoms are low, symptoms should be going up. And so which of those you think should be causing the patient to have symptoms of seizure? Is it sodium? Is it potassium, calcium, magnesium, based on the lab value you got? So it's glary that you get the same potassium and sodium, but calcium is also low. Remember, when your symptoms are low in terms of calcium, when the value is low, your symptoms will go up. So this is 7.2 is calcium is the problem. So these are two. So this doesn't do that. Magnesium is normal. So it's not going to have seizures. So it's mostly sodium and calcium. So those are the two that was causing the problem. And this is assessing a client with end-stage renal disease who has mixed 3 dialysis sessions, which finding the next you expect. The board can ask you something like that. They may not use the same word, or they trick it, but it's the same thing. Who can tell me what is wrong with this patient? You have to don't answer the question until you figure out what I'm trying to ask you. So what is wrong with this patient? Dialysis patient, missed 3 dialysis session. And I said, which of these you should expect? You have to come up with the pathway that, oh, this is what is wrong with the patient. And therefore, I'm going to pick answers that is related to that. Therefore, who can tell me what is wrong with this patient? What should you worry about? End-stage renal disease, I've given you all the buzzword. Dialysis session 3 times. What do you expect in this patient? What do you expect? A dialysis patient, fluid overloaded. That's what somebody did. Therefore, if fluid overloaded, which of this is a sign of fluid overloaded? That's how you break down the question. Which of this is signs of fluid overloaded? That's all. We have a few more minutes. Then we'll be done. 1 minute. I can do all these things. So which of them you think is fluid overloaded? Dry cough, dyspnea or exertion, long crackles, tachypnea, hypertension, bounding pulses, weight gain, leg edema, JVD, and central venous pressure of 20. I don't want you to miss any question when you see a question on fluid overloading. That's why I give you all the things you need to know. So which of this you think you will see in the patient who has dialysis, has missed dialysis section for 3 times? Which of these are you going to see in them? Signs and symptoms. Is this consistent with the fluid overloaded? Of course, dry cough is consistent with fluid overload. Dyspnea and exertion is consistent with that. Your lungs, you're going to have crackles, right? You have tachypnea. Your blood pressure goes up. Your pulse will be pounding. You're going to gain weight. Your leg edema. You're going to have JVD. You're going to have central venous pressure of 20. Usually normal is less than 8. But it's a select or apply. These are obvious if you know the content that this is all signs and symptoms of dehydration, of fluid overloaded. So that's what you see. Dry cough, dyspnea, lung, tachypnea. But I don't want you to memorize it. I just want you to apply it. But this is what you're going to expect. All of them, signs of fluid overloading. We will leave this one. And let's provide care for a client with 5 days of excessive diarrhea. Excessive diarrhea, which finding the nurse should expect on the assessment. So if I've been having diarrhea for 5 days, excessive, what do you think will happen to me? How would I look like? Then use that information to answer the question. So excessive diarrhea, what will happen? So what is, you have to rewrite the question, use the buzzword. Excessive diarrhea means what? What does excessive diarrhea means? I'm going to get dehydrated. Which of this is a sign of dehydration? So which of this is signs of dehydration? Of course, weight gain is not going to be a sign of dehydration. Dry mucous memory, of course, right? what is going to happen with your heart rate? Are you going to have bradycardia or tachycardia? Are you going to have bradycardia or tachycardia? Your heart rate is going to go up. It's not going to go down. You're going to be tachypnea, right? What is going to happen to your pulse? Your pulse is going to be tready. So this is all application, okay? Your pulse is going to be tready. How about your capillary refill less than 3 seconds? Are you going to see that? Capillary refill less than 3 seconds is normal. So you're not going to see that. You're going to be weak. Your blood pressure is not going to be high. Your skin turgor is going to be poor. And your neck vein will be flat. This is like doing fluid overloaded. Is the same thing, opposite of that. This is fluid deficit. And these are the signs and symptoms you should see. Your board will show you these kind of things. You don't have to memorize them. I know if you guys feel like it's hard, but when it comes to fluid overload, a fluid electrolyte, you got to find a way to answer these kind of questions. Think about it carefully, then you pick the answer. You don't have to memorize. Which of the following does not cause allergic reaction when infused in the client? Which of the following does not cause allergic reaction when infused in the client? There's two types of fluid. When you see this, think about two types of fluid. There's the colloid and there's crystalloid. Which one are the crystalloid? We've seen it, normal saline, LR, right? D5W, and all the different constitution. Colloid is like albumin, right? Dextran, right? Ether starch and other. Colloid are the one that causes allergic reaction. The big molecules, they cause problem. Crystalloid are small fluid and they move from one place to another. And so this question is testing your knowledge between colloid and crystalloid. So which one, okay, causes allergic reaction? It has to be colloid. This is how you can rewrite the question, and then you can figure it out. So albumin is a colloid. 3% normal saline is a crystalloid, 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 crystalloid. So there's only one answer choice. I intentionally said this way. Only one answer choice. Albumin is the only colloid that causes what allergic reaction. The rest are all crystalloid. You're not going to do anything. NS is teaching new graduates about colloid. Which of the following information the nurse should include in the teaching? Select or apply. So this is what I just said. Colloid medication, they are very big molecule. They cannot easily move from one place to another because they're big. They stay in the intravascular space. They causes allergic reaction, and they are associated with what coagulation and bleeding problem. So this is one of the things you have to know between the difference between them. So a colloid, select or apply, they are not small, they're big. They can easily move. No, they don't do that. They stay in intravascular, it causes allergic reaction, and are associated with the coagulation. fundamentals in fluid and electrolyte, and some of the questions they may ask you, some of the things you have to pay attention. You can't just memorize them. It's an application questions when they come to them, and you have to know how to deal with them and be able to manage them. Okay, guys, you guys have a good day. Good luck. If you want to learn more, you can join our crash course or on demand. You get access to that, or you can join our YouTube membership. We have Gold, NGN Gold, and where you get a bunch of questions like that and content mastering. You just have to dedicate at least, to sit down, master the content, and don't rush and go take the exams. But good luck and be safe.